What is the one thing that we as healthcare IT professionals can do to facilitate physicians' active participation in hospitals and clinics achieving each stage of meaningful use?
That's a great question, and I really appreciate it, because it's really an entree into the answer to your question. It really has to do with why are we doing all of this in the first place. It seems like it's an awful lot of hassle and an awful lot of work, but why? And it's so that we can service patients and practice medicine and care for health and health care, and reduce costs in American healthcare. It's a fundamental tool of healthcare transformation. Healthcare transformation is bringing a whole new approach to providing care. It used to be that someone could practice medicine in an office all by themselves in isolation on an island, and do just as well as they or their grandparent had done in the same kind of a practice. That's no longer possible, as we are now recognizing increasingly our commitment to the health and well-being and the care of our patients collectively as a population, as well as through the whole continuum of time. That healthcare is not just taking care of somebody when they happen to be in front of us, but rather our responsibility is before they show up and after they leave. And that's, showing up in some of the activities that we are focusing upon: the hospital readmission program, the whole emphasis upon care transitions, population health, and also quality improvement. There is such a commitment to reducing cost in healthcare, and yet we're spending all this money as the government, billions and billions of dollars that we are spending in order to put infrastructure in place so that we not only have the ability to capture and share data as we had in stage 1 of meaningful use, but also in stage 2, where we are using that structured data in advanced clinical processes that eventually, in stage 3 and beyond of meaningful use, will lead to improved outcomes for patients and for populations, and eventually also to improve the efficiency and effectiveness of care by reducing not only waste and inefficiency, but also protecting patients from unnecessary harm and making care work better throughout. So I guess the answer to the question that was posed is, how can we engage the individuals in our institutions? It's by sharing with them this vision of an improved healthcare system and the transformation that we are all undergoing simultaneously. We need increasingly to help one another in healthcare. It's the biggest untapped source of energy in healthcare, is our helping one another. We can only do that if we have a window into the opportunities to help, and healthcare data exchange is certainly one of the key tools to that kind of activity. A long-winded answer to a great question.
Any questions? Any questions for Dr. Levine? Okay. Thank you, Dr. Levine. Another question. This is for Chris and Linda. What do you see as the biggest challenge for your clients in achieving and maintaining meaningful use status through all the stages that they are currently known?
I think the biggest thing from an operational perspective is that so much of the change has to happen in so many different areas. And you know, some of the things I didn't even allude to is just, and what we heard this morning from the team about their audit is the full-blown change that has to occur in your policy and procedures, and you know, all that documentation that's required behind that. So I would see that, particularly in the work that I've done in the last year, just a whole lot of work around policy and procedure development, refinement, and kind of realigning maybe what's already established and in place to the processes that are really taking place with those new systems or new models.
Yeah, I'd say that it's the recognition that meaningful use, particularly stage 1 meaningful use, is not the end, it's the beginning of a larger track and a larger initiative, and being able to provide staff and employees some context that this is just the first step in a continuum of steps that will go on, you know, to infinity basically at this rate, and that it's not time to lose momentum. You know, a lot of folks have done some really great work from a project management and implementation standpoint to get to this stage of meaningful use, and I think I'm getting the sense, I don't know if you are, Linda, that some people are looking to take a little bit of a break, a little bit of a breath. And unfortunately, a lot of the rules and requirements, both from a regulatory standpoint and from a business standpoint, frankly, are not going to give you too much of a break at this point. The train has left the station, in other words.
I'm going to take this opportunity to put a plug in, based on what Linda said, for Kansas Hospital Association worked with PYA, apologize for that, to put together a model set of revised policies for HIPAA, and those will be available free to all of our members and the REC participants. But the policies were revised in anticipation of the final, release of the new HIPAA regulations, in addition to participation in health information exchange and trying to take into account all of these upcoming changes. So we will have those, and I think they're in the final steps. So they'll be available certainly on our website, and if you have a specific need, there'll be some training associated with that. But we had a very large contingent of hospital CIOs, privacy officers, Judy, I see right here from Stormont Vale, participate on that, but they went through and have given us a lot of input and insight into those. And so those will be available, and that's through the assistance of the REC funding that we're able to make those available at no cost to anyone.
Thank you. Any other questions about anything that has been covered today, about the audits, about meaningful use, stage 1, stage 2? Anything? Yes.
Just kind of a general question. So we have providers and now have providers and hospitals that would be submitting immunization data to all these registries. But like flu shots are given in so many areas. Are the minute clinics, where can you actually get all that data so that it's useful to you as a clinician? Because it doesn't help if it's just one way and we're sending it in.
I think in my experience, that's definitely, the challenge, the place that we're at in terms of, integrating all the data sources. And, unfortunately, I think it's farther out than what we had originally thought it was going to be. But I would see, that at some point, I'm anticipating, or, we've had some discussions about the fact that, maybe that there's going to be a requirement centered around the provider MPI level, around the participation level in Medicare, that you would have to be able to submit that level of data, whether you are, at a minute clinic place or, at a, all sorts of different care opportunities. I think that's where we're headed. And once, to Dr. Levine's point, that's kind of our end game here, is to get to that place where we're really making meaningful use of all this data.
Yeah, it's similar to what Linda said. Another compounding factor is a lot of that public health data is state-based, And so it varies from state to state a lot of times. And so coming up with coordinated policies that can basically create maybe an NPI level network of registry of that type of data would be, I think, extremely useful and efficient from an efficiency standpoint. But of course, state politics are notoriously difficult to navigate, so that's not the easiest thing to accomplish.
And the only thing I would add to that, and this is true of many of the meaningful use measures, and this is sometimes helpful for specialists to hear this. It's kind of a related item, is that all the data that's in your system doesn't necessarily have to be from services you performed. So in the case of an immunization, it's prudent for healthcare providers to collect that information from their patients. Have you had your flu shot? Yes, I did. When did you have it? Doesn't have to be an exact date, but almost every EHR system I've seen has the capability to record that immunization provided in another location, and that goes into structured data. And once the systems from those provider records are connected through HIE, then that information is going to get to the state. And the same is true for some of the measures that specialists push back on, especially initially. Well, I don't take my patients' blood pressures. I don't weigh my patients. I don't know how tall they are, but they have to have that for the meaningful use demographic measures. Well, they don't have to be the person to take the blood pressure as long as they have that information documented in their chart and it can be captured. So from that perspective, the patient medical record needs to be as complete as possible, but it doesn't necessarily mean you perform 100% of the work of the data that goes in there.
And I'm certain that KHIN certainly, and I believe Lacey will, both of the health information exchange organizations are working with connectivity to county health departments, to optometrists, to a whole variety. They're not limiting just hospitals and physician clinics. So I know their goal and intent is to bring everybody that makes sense onto that exchange so they can share that data and provide the data as well.
I have a basic stage 1 interpretation question, since there's such a brain trust in the room. Regarding the health summary that needs to be provided to the patient electronically within 3 days of discharge, I've seen that that's been changed for stage 1, and the changes will take place beginning in 2013. What does that mean for us that are doing stage 1 attestation right now? Do we need to provide it electronically or not?
Are you speaking of the clinical summary measure that has to be provided within 3 business days of a
Yes.
physician office visit?
No, a hospital visit.
Okay, so a hospital discharge.
Can someone please repeat the question?
Yeah, I don't know the hospital.
Are we being held accountable for stage 1 attestation for providing an electronic summary to the patient of their hospital stay?
Go ahead.
Dr. Levine, do you want to comment on that?
I don't believe that is the case, but I am not the subject matter expert who can answer it most appropriately.
Okay.
I don't know if anyone, I think that's not a requirement until stage 2 for hospitals, and stage 2 doesn't start for anyone until 2014. Well, or fiscal year, the hospital fiscal year.
It originally was a stage 1.
Yep, the requirements under stage 1 are that you provide a summary. It's not that
Doesn't
you
have
provide it
electronic.
Right.
Yeah.
Yeah, and in stage 2, you are correct, there is a requirement to provide electronic, but they have scaled back, way scaled back the percentage of those that have to be able to provide it electronically. I think it's a number around 10%.
That's right, yeah.
Around 10%, something like that. But what they didn't give up, what they did scale back, is you also have to have some way of being able to verify that they actually used it, got to it. And so there's a lot of debate still going on with the ONC's committee about how that's going to actually take place. You'll see additional guidance that might come out from CMS on how to do that. The frequently asked questions area of CMS on the meaningful use is a great place to go find the answers to those kinds of questions.
Yeah, what Paul's referring to is this phrase, the view, download, transmit. You'll see that a lot in the next couple of years about ways to engage the patient to meet those thresholds that they've viewed, downloaded, or the care summary has been transmitted. That's the term of art that you'll see a lot for that.
And that's true for physicians as
Yeah.
well as hospitals.
Dr. Levine, do you have any questions for the panel?
No, I do not.
Okay.
A few.
This question ties in a little bit to what Linda had said, and maybe everyone could, up there on the panel, could provide a little bit of input. But obviously, we appreciate metrics that are given by physicians for outcomes and things that were improved versus not. How important do you think it would be, as it relates to quality measures and meaningful use in particular, if you had a metric that showed medical errors or improvements in medical errors, or even errors that didn't happen and they were, near misses, for example? How important would that be to qualifying, or I guess I could say improving what you were doing with your system in meaningful use attestation? Maybe a better way to word that is that going to be something that improves the attestation, or something that helps meaningful use down the road in the next stages to come?
Of how to avoid errors.
To show that a hospital improved their errors that they reported versus errors, maybe even errors that didn't happen but they were caught ahead of time. In the same way that a patient would appreciate outcomes, percentages on improvements and things like that.
So something like avoiding never events, or something to that effect, preventing things that should never occur in a care setting. Some public, I think Medicare does too, and a lot of private payers won't pay for those already. If that event occurs, it won't be reimbursed, the care that was provided that caused that event. So there's already a financial incentive to avoid amputating the wrong limb, for instance.
Sure.
In addition to that, the Medicare conditions of participation for hospitals require a meaningful quality improvement program. And integrating your electronic data into quality improvement programs can be a very effective and efficient means of being able to meet that condition of participation.
Anyone else have any questions?
Martin, I'd like to ask a question.
Yes.
Maybe I can speak loud here. We have a partnership here with Johnson County Community College and HIMS. And I think I saw, Linda, in some of your stats about a concern about staffing and having the right type of staff. We have several H-1B grant students here. What advice would you guys give them to address those staffing needs so that they might help them with their future employment opportunities?
That's a great question. I think I was talking to some of the students earlier during one of the breaks, and just based on just the minimal information that we gleaned from the immediate survey, I would say that the immediate need is somebody that can, assimilate all the data, and be able to, meaningfully report on it. And so those types of analytical skills, I think, are going to be key. Also, just the continued, and this is something I think that's been ramping up for a while, but just the continued technical expertise in terms of security, encryption, knowing how to monitor mobile devices, and be able to write policy and procedure that pertains to those, I think are two critical areas, just in the immediate information that we provided back from the survey, and just in my own experience. Anybody else on that?
I'd say, in addition to the technical skills, I
think you're going to see huge demand for analytics skills, in particular with respect to clinical data. Claims data, administrative data has been around for a long time. We're now just sort of in the age of starting to be able to capture the data on the clinical side, and I think any you want to skate to where the puck's going to be, as the overused cliche goes. There's going to be huge demands in being able to analyze and also integrate. That's another big one. Is integrating clinical data sets with administrative data sets. Huge undertakings and big projects going on there. So I think that's another area of demand that you'll see going forward.
Just to piggyback to that, one area that we've been talking about, we make a lot of use, I don't know if everybody's familiar with the Medical Group Management Association, MGMA survey data, which is an annual report on cost as well as physician compensation. We're projecting that the need is going to be there to be able to incorporate these clinical quality data into some sort of benchmarking tool so that the provider communities and the hospital communities can look to an outside data source or analytical source other than just the payer or the repository currently for the meaningful use data. So I think that's kind of another analytical trend is how do we get to the place where we can all be talking amongst ourselves about these clinical outcomes.
To re-piggyback on what Wendy said, we're involved every day with transactions or negotiations or relationship building between different types of providers, often hospitals and physicians, where a component of the compensation arrangement is often tied to performance on quality metrics. And the demand for smart folks to be able to help develop those, verify those, monitor them, audit performance on those metrics is now not just something that's an academic exercise. There's real dollars tied to it that affects take-home pay for a lot of clinicians now. And oftentimes that'll get rolled up and affects the revenue that say, an organization like a hospital or a health system or multi-specialty practice can generate. So it's not, these clinical analytics are not something that sort of exists in the abstract now. It's real, every day we're developing these with hospitals and physician groups across the country. It's happening all the time.
I would also add that we need to know the standards. So we need to know that, something about HIPAA and HITECH and PCI DSS is becoming more and more prevalent everywhere. And get to know, the standards. It's not enough to just know the acronyms, know how to spell it. You got to know what they say. And I'm not saying you have to read 500 pages of every standard. That's not what I mean. But you have to know how to interpret that stuff, because when the hospital administrator says, generate me this report, which is what Chris is alluding to, analytical skills, you need to know, okay, why are they asking me to generate this data? And, where is this coming from? Okay, so I think that's the big thing that we're looking for when we go out to try to hire somebody with that, in that job, whether it be privacy officer, compliance, audit, whatever. Those are some of the things we're looking for. Do you know how to spell HIPAA? Seriously.
Not everyone.
Seriously, because they don't. That's exactly right. Thank you.
Another thought I was just having, it's a really good question, is that there's this new world emerging in a lot of new care models of population health management. And this is a bit selfish because I have a public health background, but there are skills that are needed under those models of care, particularly where providers are taking on risk to manage population health that are very difficult to find. There's not a lot of people out there that can do that work. From an epidemiology standpoint, from a biostatistics standpoint, even from a systems standpoint as well. So that's sort of an emerging area that you'll probably see more need.
I was going to ask the group, I'm curious, having worked with a lot of small vendors, are there reports within your product now that give you some of those good information, that good clinical outcomes, things that you feel like you can share, that you hold up and can measure on a regular basis? Are they all ad hoc? Is it do you rely on someone else to, to write what you need? I'm just curious, are there products like that on your report menu now?
We have report writers on staff that have to pull all that information out.
It's not there.
Because providers want specific details about certain counties. So we have report writers that do a lot of that. And also, we're using business audits as well. It makes sense out of it.
So what-
It's in there, but it's sometimes hard to pull out.
What product? Cerner?
Similarly, oh, go ahead. No,
I was gonna say the same thing. Your systems have the data in them, but it's not intuitive to get them out. The larger vendors are working to create standard PQRI, standard meaningful use reports, but you really have to build your systems the way the vendor wanted it built to get the data out the way you want the data to come out. It's not intuitive. You really have to know how your vendor built it to get the data out the right way.
So the people that you would hire, that you would want for that position to have those data analytics are going to need to spend a lot of time with the vendor or with the trainee and understand the database and how.
And the
things
clinicians.
are- And the clinicians.
How are they using it?
Absolutely.
That's what I was going to mention is just as an example, we were recently working with a hospital and a physician group in New York that were developing an intensivist model, and we were trying to develop sort of the quality metrics that would govern that relationship, and to run some fairly simple reports on their particular EMR to give us just some baseline statistics on where they were, then build some goals and some benchmarks off of. Not only was it difficult to get that data, extremely difficult to get that data, but the amount of time that it took to get it was just astonishing. And I think that's what we'll see more and more of a need for, is be able to turn around those reports in a much quicker fashion, or maybe even automate them as well. Because you're gonna, things happen like negotiations with managed care companies or, with physician groups where people need to know the information so they can make informed decisions, both sides of those negotiations often. So.
And if any of you have looked at the meaningful use stage 3 recommendations, which, that can change a lot.
That's kind of scary, isn't it?
Some of them I think really make good sense, but their approach is to try and present the quality data, present the information at the point in time rather than retrospectively.
Mm-hmm.
And I think that's a positive step. I don't know how easy that's going to be to accomplish, but I think the move is the right way, is to present it to you as you're during the process of care rather than, 3 months later type of reporting.
Anything else? Any other questions, comments? Yes, Judy.
What do you expect the biggest change between stage 2 and stage 3 to be?
In reviewing the recommendations? Well, one of the ones I saw that kind of concerned me, again, working with small hospitals, was they expect clinical decision support rules to go from 5 to 15, which is a huge jump. I saw a lot in there about external, and chime in, because accessing other sources, integrating with pharmacy benefit management, is that right? PBM systems, and trying to get I liked a lot of what they said in terms of trying to get that feedback so that when you send a report or you send a test out, that there is an acknowledgement documented that that person received it in terms of providers and that type of thing. But a lot of reliance on that connectivity and integration and exchange of data.
Yeah, that's what I was going to say. From a practical standpoint, it'd be exchange and probably interfacing, the need to do more interfacing. I think you'll see a higher demand for that.
And so there's another job opportunity,
yeah, exactly.
too. That connectivity support,
Yeah.
I think.
Yeah, and how do you ensure that connectivity is secure?
Right,
Yeah,
right.
it's minor
Right.
detail.
That stuff.
Okay, any other comments? Thank you. Going once, okay. Well, listen, we appreciate the panel. Dr. Levine, thank you very much for participating.
You're very welcome.
And panel, we thank you for participating time out of your busy schedule. They're going to be available afterwards if you have any questions or anything like that. We ask you to be sure to complete the survey. Take time to complete the survey. Also, the presentations that you saw today will be on our website.
About 24 to 48 hours.
24 to 48 hours, HOAHIMS.com. Org.
Not for profit.
Not for profit, that's right. Okay. Also, there is lunch back here. We invite you to mingle and to network and just to get to know each other and to have lunch, and we very much appreciate. Paul, anything you want to say, or?
No, well, briefly, I guess.
Okay.
Sometimes I can't help myself. Again, thank you, panel, for joining us, especially Dr. Levine from remote locations and those that have traveled. This organization, HIMS, the Heart of America chapter here in Kansas City, is your chapter. And I realize how busy everybody is. But we could use as much help as possible from volunteers on our programming committee to help us put the events like this together. The networking opportunities are actually very, very nice. Those, when they happen, they're not about work. They're just about getting to know each other. We usually have a little bit of food there, and it's BYO, well, you buy your own drinks. But it is great opportunities also for our students in these programs to get to know you guys and understand what you're looking for in your employer space as well. A lot of this information we've been talking about here today is again available on the CMS websites, and there's also monthly public broadcasting via webcast and audio of the ONC's advisory committee out there that's talking all about these meaningful use, stage 2, stage 3, what they're thinking. And I challenge you to go listen to one of these, because a lot of the work they are doing, while it is all very much whiteboard and looks good in a perfect world when you're talking about it, there are physicians on these committees who are talking about the reality and the challenges of it, but they continue to press basically the gas pedal, and this is not going away. This is the new norm, is the continual pressure for better outcomes, lower cost, better care. So in your employment community, in your networking and professional communities, understand that this is the new norm of healthcare. And active participation really is required for this to work for all of us. So thank you all for coming. Thanks to our panel. And please enjoy the lunch afterwards. And I hope we get to see you guys at our April 4th event here, and also at HIMSS National coming up in March 4th, our breakfast. One more thing?
Also, if you have, the whole purpose of this on the programming with Linda Gerber's the programming chair, is we want to put together subject matter that you want to hear. That's important for the hospitals, that's important for the physicians. If you have any suggestions or comments or something like that on what you would like to hear in the future, you can go on our website, you can go to the programming chair or any of us, and email saying this is something that our hospital or our organization or our clinics or something we'd like to know about, or we'd like to learn more about. That's the way we formulate some of the programs on what you would like to hear. Okay? Thank you very much for coming.
Thank you.
Thank you.